Good morning, everyone. Welcome to Coffee with the Commission. This is a time where the WMC discusses topical issues that affect you. Today, we will be talking about changes to our application with respect to personal data questions. I'm joined today by Dr. Chris Bundy, Executive Director of the Washington Physician Health Program, also known as WPHP, Dr. Pam Kohlmeyer, Staff Attorney for the Washington Medical Commission, and Ms. Marissa Courtney, Licensing Manager for the WMC. Before I turn the webinar over, I'd like to take care of a few housekeeping items. We encourage you to ask questions throughout the presentation, so look for the chat box on your webinar portal and we'll do our best to address your questions at the end of the presentation. We are recording this webinar, and the on-demand version and the slide deck will be available on our website within the next few days. Please feel free to share these resources with your friends and colleagues. And with all of that out of the way, I will turn it over to Marissa.
Thank you, Jimmy. Thank you all for joining us today. This is a very exciting topic that we are happy to present to you. First, I would like to go over some of our changes with the personal data questions. So let's go ahead and get this started. So to give you a little bit of understanding of what the personal data questions are, all applicants must answer the same personal data questions that are listed in the initial and reactivation application for licensure in Washington. They're focused on providers' fitness to practice the essential skills of their professions. And the questions typically range from substance use to malpractice suits to board action. There's other questions in there, but those are the main ones that we look for in the application and the ones that typically provide a answer. So the applicants must provide us with a yes or no answer for each question. If they mark yes to an actual question, it's the applicant's responsibility to provide us with a written statement or an explanation. And depending on the question that they answered yes to, they must also submit documentation related to the incident or a case. Okay. Changes over the years. The Medical Commission is continuously reviewing and updating our applications, not only to make sure that they're easy to interpret, to make sure that the applicant can understand what exactly they're being asked of, but to also make sure that the questions are actually relevant to what we're wanting to see from our applicants. Over the past 5 years, the Commission has updated their personal data questions 3 times. Originally, we've had questions over the years. They have changed the number of questions, the type of questions, but I wanted to focus at least within, starting out at 2012. We originally had 15 questions in the application. In 2018, the Commission revised some of the questions, and regarding paraphilic disorders, we completely removed that, and we combined questions related to board action. This dropped our numbers from, the number of questions from 15 to 13. I would also like to highlight, and I apologize it's not in here, that this was actually a start of a collaboration with WPHP and Dr. Bundy that started in 2017, but the questions actually went live in 2018. So looking at the history of those questions, it was also at the guidance of WPHP that we're able to change some of the terminology and some of the questions to help our providers understand a little bit more of what we were looking for. In 2020, the Commission reviewed the application again and combined another set of questions related to malpractice and changed, again, some terminology and language to help reduce the number to 12. And then in 2022, we partnered with Dr. Bundy again and WPHP to completely revamp our questions again to make sure we had a clear message and to provide questions that were easy to understand and provide a safe haven statement to encourage our applicants to utilize if they had any personal medical conditions or anything that could possibly negatively impact them or impact them to be able to practice medicine in Washington. With this new version, the personal data questions are now standing at a number of 9 questions total. And then just to give you kind of a snapshot of what is the Safe Havens attestation that's in our application. Dr. Bundy will actually kind of go over this in more in depth, but I wanted you to actually see it since as of right now, we are working to actually put our personal data questions on the website, but unless you are an applicant right now, you're not able to view it. So we wanted to highlight it here for you. Go ahead and turn it over to Dr. Bundy to go into more details.
Well, thank you, Marissa. Awesome. So our involvement in this began, as Marissa mentioned, in 2017. We approached the commission, being involved both locally and at a national level in licensure question reform efforts. Best practice was evolving at that time, and I just wanted to really give kudos to the medical commission for its willingness. They really embraced the idea of bringing questions into alignment with both ADA and also with asking all questions that really only had to do with current impairment and not wanting to ask questions that would discourage prospective licensees from seeking help for mental health, substance use disorders, or other conditions out of a fear that there would be adverse professional consequences, including potentially adverse licensing action as a result of having been sick and sought appropriate care. So it's really been a multi-year journey, ending with what is now considered the best practice, which is not even an attestation model. This is an advisory model where they're not asking questions about your protected health information. They're simply saying that if you have a condition that could impair your ability to safely practice, you have a responsibility to take care of yourself and provide some resources for how to do that, and includes mentioning that if you're known to WPHP, you're considered to be in safe haven with regard to any potential issues of impairment. The attestation or advisory actually goes on to say, however, that and this is fine, this is completely in alignment with ADA and best practice, that that the commission does have the right and will look into information regarding impairment that may come to light as a result of licensure or an investigation of a complaint. And in that way, WPHP can also be helpful. So we are, here to help that 1% to 2% of folks, or maybe more, that might be either impaired, frankly, in the workplace as a result of a health condition, or at significant risk of impairment. Rehabilitate the professional and protect the public. Sometimes people think that things are working in tension against one another. We actually believe that there's perfect alignment between those two goals. Next slide. We've been around for really almost 40 years now in the state doing this work. There was a seminal article published in JAMA in 1973, actually, my slide's incorrect, called The Sick Physician. And I know that the slide's incorrect because this February, we actually celebrated the 50th anniversary of this seminal publication, which really kicked off the physician health movement nationally. Within 5 years, some 80% of physician health or state medical associations, state medical societies had implemented some sort of peer assistance program, meeting the call to action that the sick physician represented. in Washington, that was the Committee on the Personal Problems of Physicians that was stood up by the Washington State Medical Association. And after a little more than a decade of doing that work inside of the medical association decided it was time for it to spin that out to its own program, an independent nonprofit organization originally called the Washington Monitored Treatment Program, which would have its own board of directors but still have governance ties to the State Medical Association to organize medicine in Washington. We changed our name in 1993, and since then have been really the structure and function of WPHP has been the same, with obvious advancements and innovations over time. But we are a physician-led, independent, nonprofit organization funded by the license surcharges that physicians and the other licensee groups that we serve pay when they get or renew a license. And as I mentioned, we're governed by a board of directors, as are all nonprofits, and that board of directors has to be approved by the executive committee of the Washington State Medical Association, as do any changes to our bylaws. Next slide. I think in terms of our model, we are a voluntary program. Not to say that people who come to us aren't sometimes being encouraged to do so by an employer or credentialing entity. Sometimes on initial licensure, if there have been issues in the past that require WPHP to provide reassurance to the regulator that individual is safe to practice and ready to be licensed in Washington. It's a confidential program and it's an alternative discipline. Some people think that we're actually part of the medical commission or that we're part of the medical board. In some states that's true. In a handful of states, probably 5 or less states, is the physician health program an arm of the regulatory entity. But in Washington, that's not the case. And although we are not part of the disciplining authority or the regulatory body in Washington for the health professionals that we serve, we like to think that it benefits our participants and folks that may be board involved, that WPHP does have a mature collaborative relationship with the regulators that we work with in Washington. Next point or bullet. We have excellent outcomes in our program, and that is due to the accountability and chronic care management model that is the basis of how our organization operates and how we interact with our participants. That promotes safety and provides the basis of advocacy that we provide for folks, whether it's in employment or licensing or credentialing, insurance, and other places where doctors who have had difficulty in the past may need some help from WPHP to provide reassurance that they're safe to practice and good to go. I will say, because we've been doing this in Washington for 40 years, our endorsement of doctor safety to practice, in my experience, goes a long way with both the regulatory body and with hospitals, credentialing entities, and employers, and insurance contracting, and so forth in Washington. Next slide. We do have a requirement mandated in statute to report individuals to the disciplining authority who may be unsafe to practice. We wouldn't have the privilege of being able to offer this voluntary, confidential alternative to discipline if we didn't execute on that statutory reporting obligation when necessary. And I'll say more about that in just a second. Next slide. And now is just a second. So reports to the disciplining authority by WPHP are relatively infrequent. You can see that we had 5.5% of our cases in development, pre-monitoring cases, which I'll show you what that means in just a couple of minutes, and 2.9% of monitoring participants. Historically, this has been below 5% for both cases, and currently over 85% of WPHP participants are voluntary or unknown to the disciplining authority. So the vast majority of people who are actually working with us are not board involved and have self-referred and are part of the voluntary track. Our process is, as I mentioned, is a case management model. individuals are referred to WPHP, we do the intake referral and initial assessment. The goal of our initial assessment is to determine whether or not somebody really needs to be involved with WPHP or not. We do a little bit more involved initial assessment than other physician health programs with the goal of being able to clear people and help them avoid unnecessary, costly assessments that are inconvenient and difficult if possible. Sometimes we can avoid that. The circumstances of the referral or the findings on initial assessment suggest that something more significant may be going on. And for that, if we need an independent evaluation to establish diagnosis and make recommendations for treatment, we do that through outside providers. So we don't provide diagnosis for the purposes of making monitoring decisions or WPHP involvement decisions. If we get to that point where we're thinking somebody might be needing monitoring, we do an independent evaluation. We also don't provide treatment in WPHP. We do, however, provide monitoring when it's recommended. Next slide. A lot of folks think that getting referred to WPHP means that you're going to be found to have a health condition that requires monitoring. The data really would suggest otherwise. Last year, and this is typical of most years, we monitor less than half of individuals. 43% were enrolled in a monitoring agreement of those initially referred to us, and only 80%, so about 20% of people that got referred to us, it was just a report of concern. There wasn't enough there to really warrant in having that individual sort of come in and be evaluated by WPHP. So in a lot of cases, we're doing work really upstream of impairment, trying to provide service and support to people, to put concerns to rest when needed, when there might be a concern of impairment. And it's also worth noting that 60% of our referrals today are for non-substance related concerns. So oftentimes physician health programs are thought about as substance use disorder programs, but we really see the whole waterfront of concerns and issues that could be related to impairment. Next slide. I think in terms of kind of talking about safe haven non-reporting and how that interfaces with WPHP, it really demonstrates that the Medical Commission considers WPHP to be a trustworthy, safe alternative to discipline for purposes of licensure application renewal. I've certainly never seen it be the case that WPHP participation alone is a basis for adverse licensing or disciplinary action. In fact, I've seen the opposite, that involvement with WPHP can provide reassurance to the regulator regarding licensing and or disciplinary matters. Involvement with WPHP can reassure the Medical Commission that you are safe and that our endorsement can help resolve impairment-related licensing concerns without as much intrusive regulatory inquiry into protected health information. In other words, the Medical Commission is often willing to take our endorsement of safety at face value without then pursuing further information that would, again, those kinds of inquiries discourage help seeking among health professionals. And with that, I think my comments are concluded for now, and I will hand it over to Dr. Kohlmeyer.
Dr. Kohlmeyer, before we move on, Nicole had a question. Nicole, do you want to unmute yourself and ask that?
Sorry, did I unmute myself? Was that successful?
Yep.
Oh, good.
We can hear you.
Oh, great. Thank you so much. Yeah, I had some questions for Chris Bundy about reassuring the Medical Commission or saying that their endorsement reassures the Medical Commission when supposedly it is confidential. I mean, in what way does WPHP's endorsement, which I understand from having represented several WPHP quote unquote participants, you guys don't give endorsement letters or clearance letters or say, yes, you've completed our program compliantly or whatever. Because if someone does complete the program compliantly, the Medical Commission never hears about it, correct? So in what way is WPHP's endorsement, should that ever be, in what way can they ever endorse, basically, without revealing confidentiality?
Well, I think it's a great question. Thanks for asking, Ms. Lee. The way that it works is that every participant in WPHP is required by statute to sign a consent so that we can communicate with the Medical Commission. So those are all consented communications, and we only act on that consent. We only communicate with the medical commission when to do so has been endorsed by the participant, meaning they want us to talk to the commission to help them in a disciplining matter. But there's also situations in which we have a requirement to forfeit that individual's confidentiality because of a statutory reporting obligation. And as I mentioned, that's relatively unusual, but there's lots of advocacy work that WPHP is doing that's really, sort of out of the purview of individuals who are license involved or medical commission involved because of some difficulty with either compliance with WPHP or disciplining issues that WPHP can't help them resolve.
Well, still on that confidentiality point, do those individuals know that you're speaking with whoever you are speaking with about them? Does
Yes.
that individual ever get to know? So if the participant says, "Who have you been talking about me, and can I see whatever your correspondence is?" You guys provide that?
I don't know that we would say we would provide whatever correspondence is. I would say that we don't typically talk to the commission without letting the participant know that we intend to talk to the commission. So in the case of a mandated report, a participant always knows that we're going to be making a notification to the commission before we make that notification. In cases where we're working with them on advocacy issues, yes, we have pretty explicit conversations with our participants about what conversation we intend to have with the commission, who we intend to talk to, what the nature of that conversation will be, and how it will help them.
I have a bunch of questions, but I don't want to take up too much time.
Okay, I'm Dr. Pam Kohlmeyer. I am a staff attorney and medical examiner, hearings examiner for the commission. And my comments are going to focus on the impact of licensure questions on physicians and PAs, and frankly, the patients that they treat and the public's health. And I'm going to do that under the framework of something that's a mantra for doctors, which is first, do no harm. Do the next slide. So in the next, 14 slides, but they're short, I will try to help you understand the why behind the change in the licensure questions. It truly is a good thing. And I'll try to help you see that by using a real life example outside of medicine might make it more clear. So after practicing as an emergency physician for about 15 years, I decided for some reason to go to law school. And in law school, because I'm a doctor, people would talk to me about medical issues. And one law student shared with me that he, she, they stopped taking their anti-anxiety medication because they didn't want to have to disclose a mental illness, anxiety, on their bar application. Now, let me tell you, if you have anxiety and you are in the highly anxiety-provoking environment called law school, you are preparing for an anxiety provoke, and then follow that with a bar exam, which is also a high anxiety exam. The last thing you want to do is incentivize in any way someone from stopping their medication that helps them. This is a recipe for badness. As medical providers, we know that, and yet our very own licensure questions across the US previously promoted such a scenario. Next slide. Oh, actually don't. This is a good slide to show that there are states taking notice. So the Washington Medical Commission is among 18 other state medical boards that have updated questions to help reduce stigma, especially about mental illness and substance use disorder, and also promoting physician well-being and PA well-being and health provider well-being. Okay, next slide. So note that I said that Washington has joined 18 other states in updating licensure questions to promote provider well-being, which sadly means that the majority of states may still need a little prodding. This next slide here shows that there are efforts to try to help enlighten other states to do what Washington has done. And I'm going to share them just because they help understand this issue a bit more deeply. So this is a slide that shows 3 senators who have written a letter to the Department of Justice saying, hey, medical boards might be violating the Americans with Disabilities Act by the probing questions that they're asking. These questions both discourage many applicants and licensed physicians from receiving care that they need, and they also violate Title II of the Americans with Disabilities Act, which forbids public entities from discriminating against qualified individuals on the basis of disabilities, which includes mental health conditions. Okay, next slide. So as a reminder, so what are disabilities that are protected? Well, a disability for an individual is someone who has a physical or mental impairment that substantially limits one or more major life activities, has a history or record of such an impairment, or is perceived by others as having such an impairment. Okay, next slide. So reducing stigma. So this slide really gets to the heart of this issue, and that is that we as a medical profession, we should not only be helping to make sure that we're staying, safe and healthy, but the message we send to the public too is important. And by these stigmatizing questions before, if you've ever had a mental health problem or whatever, it promotes stigma in the community, which is also harmful to patients. Okay, next slide. So I put this slide in just to alert you to the fact that I said that I practiced emergency medicine for 15 years before embarking on the legal world. And there's an emergency physician in the state of New York, Dr. Lorna Breen, who died by suicide during the pandemic. And a foundation was started in her honor to highlight this is an issue that needs to be dealt with, not just to save lives, but to protect public safety. And on their website, which I would encourage you to just, hop onto sometime to read some of their information, but they disclosed that 400 physicians die by suicide each year. That's a huge number, right? And we already have a physician shortage. So the last thing we want to do is create more issues. And I'll also say too, that during the pandemic, especially, a lot of providers, even with no previous history of mental illness, really are suffering from burnout. Like 42% of physicians, I would actually say it's probably even higher, but 42% according to a survey. And they found that physician burnout causes a rise in medical errors by like 200%. And so if you want to think about protecting public safety, you want to address burnout as well, so medical errors could be addressed. Bottom line is, seeking help for burnout, mental health, and other health conditions helps providers and the patients that they treat to stay safe. Okay, next slide. So there is the physician or the Federation of State Medical Boards has a policy that they drafted on physician illness and impairment. And I'm going to share just a couple of statistics that they put in that report. And one of them is women physician respondents. They found that 44% did not seek help for their mental health difficulties listed licensure questions as a reason why. So think about that. So they recognize that they need some help, but they don't want to seek the help because they're afraid of licensure issues. Now, similarly, there was a different study that they cited that spoke with surgeons. And these were surgeons who experienced suicidal thoughts over the previous year. And 60%, so the majority, stated that licensure questions would make them more reluctant to seek help. Okay, next slide. So there are 3 main points from that policy, the FSMB policy, that I want to highlight. One is a quote from the paper that says this: physicians must be afforded the same access to care as the general public. Yes. The other one is differentiating between illness and impairment. So the old questions used to be like, do you have a history of ever having an illness? As opposed to, are you impaired because you're not getting the help you need and that illness leads to impairment? And now that becomes an issue for public safety. So physician impairment is what is really being looked at now. And if you have an illness that needs help, you're encouraged to get the help you need so you don't become impaired and don't ever need to cross ways with the commission. Okay, next slide. So being in law, I love the balancing scale. And so this is just a visual to help you see that with your provider medical conditions, it really is like a balancing scale with the commission. They're trying to promote public health by encouraging providers such as yourself to seek evaluation and treatment versus ensuring patient safety. And ensuring patient safety is not just the patients that you treat. You're a patient too, right? Each one of us as providers are patients as well in some way. Might not be mental illness, it might not be substance use, whatever. So this is to summarize that kind of applicant acknowledgement agreement. If you want to call it an attestation, it's really just acknowledging that by submitting your application, you understand this. It encourages providers such as yourself to seek the help that you need to prevent illness progression to impairment. It prevents impaired providers from putting patients and the public at risk. It decreases the need for the commission to ever become involved to protect the public from you. And it helps the commission honor the Americans with Disabilities Act by protecting your privacy. Okay, next slide. So what are you attesting to? Like, what did Marissa say that now that you've heard a little bit more from Dr. Bundy, you can hear again? If you currently have a medical condition that may limit or impair your ability to practice medicine safely, you understand that it is your responsibility to contact WPHP. Being known to WPHP means that you are complying with all WPHP requirements for evaluation, treatment, and/or monitoring. If you currently may be impaired by a medical condition that is not known to WPHP, the commission may require an evaluation with WPHP and/or for you to obtain other health examinations at your expense. By submitting your application for licensure, you consent to those exams if they think, WPHP thinks they're needed, and you consent that those examination reports may be shared with the commission. Otherwise, your application for licensure may be denied, which is reportable to the data bank. So that's important to know. Okay, next slide. So in other words, so this is the slide I'd like you to just process. You must voluntarily self-refer to WPHP if you are impaired. If you know that you're impaired, seek help. If you don't, and the commission learns you may be impaired and pose a threat to public safety, the commission may require you to undergo an examination and to consent to the commission accessing that information through their reports. Or your application may be denied, which would be reportable to the National Practitioner Data Bank. Next slide. So definitions matter, not just in the law, but they matter. And so I wrote 5 of them here that are important when you look at the licensure questions to reflect on. At the very top, currently means within the past 6 months. So, and we're going to break this down in a moment, but the past 6 months. Substances, those include alcohol, drugs, or medications, whether taken legally or illegally. Medical condition includes social, behavioral, physical, physiological, and psychological conditions or disorders known to a PHP like WPHP. You have informed a PHP of your current medical conditions and are complying with all PHP requirements. And safe haven, general protection offered in the application process by the commission for current medical conditions if known to a PHP. Next slide. So this slide I love, and someone named Taylor helped me with this at the commission, and I thank her very much. My technology skills are not that great. So the question that addresses health on our form is, do you currently use any substance that impairs in any way your ability to practice with reasonable skill and safety that is not known to a physician's health program? If yes, explain. So currently, within the past 6 months, substance includes alcohol, drugs, or medications, whether taken legally or illegally. Not known to a PHP means you have not informed a physician health program, like Dr. Bundy, of your current medical conditions, and or you are not complying with all a physician's health program requirements. That is the question. All right, next slide.
I hope everyone will join me in a virtual round of applause for our panelists. Thank you so much for speaking today. Please use the chat box to ask any questions you may have. We do have a little bit of time for discussion. But you know, while folks are typing something in, are there any like last thoughts that any of you would like to share to kind of wrap things up?
I just will share that this is, you know, an incredible amount of work that's been done by WPHP, by the Medical Commission to lead the country really in best practices with regard to licensure question reform. This has spun off credentialing question reform. This was really the foundation for getting the Washington practitioner application changed to comport with best practices. Being able to use this as an example is helping ongoing efforts at the national level. So I really think that Washington stands out as a place where the Medical Commission has sent a clear message that it wants its practitioners to be well and healthy and to seek help when needed.
Yeah, I would echo that. As a mother of a child that died by suicide, I understand the impact of mental illness, not just on people, but families and communities. And please get the help that you need. This is something that shows your patients that you're strong, you know, to get the help that you need, to be a better provider, be a better person in general, and to keep practicing.
We had someone a moment ago raise their hand. You don't have a name associated with you, but if you would like to ask your question, please feel free to unmute yourself.
I was gonna ask a question, but still fear repercussions by other state medical boards, which I'm still involved with years later. So I'm gonna withdraw a question.
Okay, well, if you would like a clarifying question, if you need more information, our email address is up there, our website's up there. Please feel free to reach out later if you feel comfortable. We're here to help. Nicole, you want to go ahead?
Yes, thank you. I had a question about suicides, because once upon a time, WPHP was required to tell the commission the number of suicides of its participants every year. It no longer has to do that, which is, I think, very surprising. So I'm curious, can you tell us how many people suicided in WPHP last year?
So that question from Nicole is a statement that's inaccurate. The recording to be the case that we've never actually been required to report suicides as part of our our contract with the Department of Health. However, we voluntarily chose to start reporting suicides a few years ago when concerns about physician suicide really came to the forefront during the pandemic, and we wanted to be as open and transparent about that as possible. We've had 5 program suicides in the last 12 years. That's the period of time for which we have collected data that's reliable on individuals who are involved with WPHP who have ended their lives. It's always a tragic and unfortunate experience for us. Last year, we had an individual who had been referred to WPHP who hadn't really been involved with us, but ended their life prior to being involved with us. So it was a suicide that we were aware of, but not one that we were particularly involved in. 25% of our program participants at program exit report that WPHP actually saved their life. So 1 out of 4 individuals in the program. So we're pretty open about program suicides and adverse outcomes in the program. We think that's a critical part of our mission and our commitment to the healthcare community in Washington.
Okay, also, sorry, somehow I got muted. Just for the record, I want to say that information doesn't reflect what I've heard directly from participants and the families of people who are no longer with us. You directly attribute WPHP as a reason for their suicide, not the licensing board, WPHP.
All right, seeing that we don't have any written questions, I'm going to thank our panel again, and I hope everyone will join me in a big thank you. Again, our email address and our website are on the board, and if you have any questions, please feel free to reach out. So thank you, everyone.